All right, we have kind of a packed agenda today, just as we have in the previous webinars. So I'm going to go ahead and jump in and get started. Welcome and thank you for joining us today for Emergencies Department's Homelessness and Medical Respite Care, the third in our series of Homeless in the ED. Welcome to those who are joining us perhaps for the first time as part of this webinar series today. And if you're interested, our previous webinars in the series are now available and posted online for viewing. And for those who have been to the previous ones, welcome back and thank you for continuing this conversation with us that we've been having over the month of March. So before we get started today, I just want to make an acknowledgement that this presentation is supported and funded by the Health Resources and Services Administration. However, that the knowledge reflected and content reflected in the presentation itself does not represent HRSA, HHS, or the US government. And also a disclaimer that the opinions expressed by our panelists are their own and not necessarily reflective of the National Health Care for the Homeless Council. So before we sort of dive into the didactic and the content and the knowledge overwhelm, bringing us back and tying into our previous conversations that we've had in this webinar series, thinking about and talking about really breaking down stigma and bias for people experiencing homelessness, we've been talking specifically in the emergency department. And as we were reflecting on and developing out this series, a memory sort of came to mind when I was an early and young clinician working in an inpatient psychiatric unit in a very busy urban area hospital. And I remember rounding one morning and they were talking about a client who'd been admitted the night before from the ED and really having this conversation around why they were admitted, what needs they were, clinical needs were presenting. And there was sort of this discussion and a very, I will say, judgmental discussion around why the person came to the ED. And I remember very distinctly either one of the residents or physicians in the room saying, I really think they're just looking for a place to sleep, and kind of ended the conversation there. And it really stuck with me, I think, especially as a younger clinician, thinking about and unpacking, the removal of humanity from that particular statement, right? That we're sort of boiling it down to, well, this person doesn't need our care. They're just here looking for a place to sleep. And I want to pose that question to you all because really we want to think about why is coming to the ED or even admitted to a locked inpatient psychiatric unit the preferable place, the last resort that a person has for being able to get a good night's rest. And instead of thinking about that judgmentally as they're using resources they shouldn't be using, to think about what is happening that is the situation that they're in and how is that contributing to what the health needs that they have and are, and really reframing our language around that and thinking about why is this person here and what's going on. So as we're unpacking that, right, thinking about and reframing instead of, oh, they're just looking for a place to sleep, they're using the hospital as a hotel, really thinking about what is the person lacking that coming to the emergency department was the safest and most restful place they can access. I think all of us have probably encountered the emergency department at some point as a provider or as a patient ourselves, and it's probably one of the least restful places that I have ever been. That thinking about, is that really a place that people go to rest and recuperate and why? And also thinking about what else is happening with their health that may not be immediately visible. Perhaps they were coming and seeking a safe place to rest, but also what is going on, what is underlying, what maybe are they having difficulty articulating about why they don't feel well, why they don't feel like themselves, that has then brought them into this setting. And in that, and reducing the stigma and bias, I want to also recognize the moral injury that happens to providers in these particular settings. And I think we start to take the humanity out of things because we start to think about all of these systemic pressures that are happening, right? And the perspective is, I don't have enough time to care for the people that really need it, especially within the last couple of years. There's not enough space for people in this hospital, in this emergency room that really need care. And that becomes the thinking so that we lose the patients for those who come in that maybe don't have that emergent and prevalent need. And I think there's a lot of moral injury that happens as well when we think about what we're able to actually do as healthcare providers and the burden placed on the health system in certain ways to not only address the emergent medical needs, but all of these underlying factors such as housing instability and homelessness that are bringing people in. And as clinicians feeling very equipped to address those emergent medical needs and feeling really not equipped to address some of those underlying things that are happening. And that that burnout and that injury that happens is what often contributes to that thinking, and then that frustration with the person who is maybe simply just looking for a place to sleep. So as we continue our conversation and continue our own work past this webinar series about working with individuals experiencing homelessness, I just sort of want to put out there for us to think about what are systemic issues that are really frustrating for us, and how can we prevent ourselves from placing those frustrations with the systems that aren't working well and taking that away from the person that's in front of me that really does need, as Dr. Work talked about and as Dr. Ingonando's talked about in the very first webinar, not, that we're treating people well when they're in front of us, that people are feeling like they are human beings when they're here. So one of the ways to address some of these systems inequities is through the development of medical respite care. So I'm going to provide a little bit of a background today on what medical respite care is. I will acknowledge there's a lot of resources and could talk the whole hour just on what is respite care, but really providing a brief background and overview for us for the purposes of our discussion today. So medical respite care is post-acute care for people experiencing homelessness who are too ill or frail to recover from an illness or injury on the street or in the shelter, but who do not require hospital level care. So medical respite is short-term. Folks are able to go into medical respite programs to finish the recovering and healing process when they no longer need hospital level care or an increased level of support, but are able to do so in a way that is not available when you're experiencing homelessness, regardless of where you're staying. One of the challenges, I think, in describing what medical respite care is that programs look really, really differently dependent on where they are, what their resources are in the community that they're serving. So we really see a big diversity in programs by the number of beds. I think our current range is there's programs that have 3 beds and programs that have 210 beds. Their facility type, where they're located, how long folks stay. Again, some programs are really focused on folks being admitted for 2 weeks, while others are able to keep individuals longer for up to a couple of months. Staffing and services provided are also going to be variable depending on the structure and the needs that are being met, as well as who is referring in and what the admission criteria is. Although I will acknowledge that hospitals are one of the top referral sources for medical respite programs. And where does medical respite care fall within the healthcare continuum? So when we're looking at this, you can see medical respite care is in red, I believe on the very left of your screen there. So medical respite care is not equivalent to some of these higher levels of care, such as inpatient rehab or skilled nursing facility, but is a community-based care setting for folks to be able to receive services like home health care, as well as continue their recovery. So again, acknowledging and just to minimize any confusion, medical respite care is not equal to a skilled nursing facility, nursing home, assisted living, long-term care, or supportive housing. So it is not long-term, it is not a venue of housing, and it does not provide the same level of care that you might find in a skilled nursing facility, which often requires 3 hours of rehab oversight by a nurse every day. It is a different level of care than that, although medical respite may be a very appropriate place for someone in a skilled nursing facility who is experiencing homelessness to transition to once they're more independent in their activities of daily living. And that really reflects a lot of the admission criteria and requirements for folks to be referred into respite, is that the level of care provided is that folks really do need to be able to independently complete their ADLs, and is a short-term stay that hopefully transitions individuals into housing, and if not able to do that, able to navigate safely within their community. There are several key components of medical respite care. I know I talked about the diversity of programs, but despite this diversity, there are some really critical elements that make up medical respite care. One of the first key elements is the case management and care coordination piece. So people coming into medical respite programs often have multiple complex conditions that they're managing, have complex follow-up care plans, new medications, all kinds of things that they need to do. And the case management piece is really critical in helping them navigate the healthcare system to address those things. Additionally, because we know social determinants of health really impact what we can do and how we can manage our healthcare, case management is also really essential in being able to address those needs, such as applying for housing or accessing basic things like birth certificates and IDs that are going to facilitate access to some of these other resources. Another key component of medical respite is integration into primary care. One of the goals is to connect somebody with a healthcare provider that is going to be able to follow them long-term, help manage their health conditions, monitor for worsening of conditions, and support better health overall, which is required to do so. It really requires engagement with a medical provider long-term in the community. Medical respite care also offers an opportunity to receive clinical care. In some cases, the medical providers are staff of the medical respite program. In other cases, the clinical care is provided through a partnership, through a federally qualified health center, perhaps home health, or any other number of combinations. But people are able to receive the care that they need to continue to manage their condition in the community once discharged from the hospital. And then finally, a core component is developing the skills for self-management, especially if somebody has a new condition or is really recovering from an exacerbation of a condition. There's new skills that might be required for self-management, or simply because they have been living on the street or in shelter, haven't had the opportunity to focus on their health. And the stability of medical respite care, ensuring that they have a place to rest and meals to eat, allows them the time and space to really focus on what they need to do to manage their health. So additional key components of medical respite care is that somebody has 24-hour access to a bed. Individuals are still sick and recovering, and so they need to be able to rest and lie down as needed in order to safely recover. 3 meals a day, transportation to any and all medical appointments, again, facilitating that connection to outpatient and community-based care. Access to a phone at minimum for telehealth and to communicate with medical providers around scheduling appointments, calling in refills, prescriptions, all of those things that happen over the phone to manage health. A safe space to store personal items, and then a wellness check at least one time every 24 hours by a medical respite staff. This doesn't have to be a licensed clinician, but really someone just laying eyes and making sure that the person is doing okay as part of their recovery process. And these are elements that you're going to find across every respite program, regardless of their facility type or staffing structure. So there's a lot more details about what medical respite in the United States looks like. Courtney's going to jump a link in the chat for us to the state of medical respite care, which is a really fun tool to dig into the details of what medical respite looks like. I'm just going to highlight a couple of things here. When we're looking at the facility type, as you can see here, a lot of medical respite programs are shelter-based within the shelter or are standalone facilities. Although there's a number of other programs that operate in different models, especially motel hotel rooms. That was a little bit of an uptick after COVID-19 and alternative community sites and the need for isolation. And as I mentioned earlier, there's a huge range in bed capacity of programs. Don't be intimidated by the 210 number. Most programs, their average capacity is at about 17. So depending on the size of your community, and if you're thinking about opening respite, starting a smaller program can still make a really meaningful difference in your community. So I want to sort of step back to our first presentations and thinking about the data around people experiencing homelessness and ED usage that was brought up. So in our first webinar, it was identified that for people experiencing homelessness account for about 0.5% of all ED visits, although we know that this is underreported, likely due to coding and how that information gets entered into people's medical charts. But there's a substantial number of folks who are more likely to return to the ED within 30 days after discharge, and 40% more likely to return to the ED after admission from the hospital. So although it's not a huge number of people presenting to the ED necessarily, they are more likely to come back. And that, I think, is of concern for hospitals and ED providers as a whole. But we want to challenge this because I think there is a perception that people experiencing homelessness overrepresent the number of folks who do come into the emergency department. And that's not necessarily what the data shows, right? And one of the things, there was a very recent publication, is that it's in part of the stigma. And thinking back to that client from my initial example, right, of, oh, he's just looking for a place to sleep. When you go back and look at records, it's very hard to differentiate what constituted an emergent ED visit versus non-emergent, right? And so sometimes we have this perception that people experiencing homelessness are mostly coming in for something that's not an emergency. That the data really tells us that we can't make that differentiation, and then that's not particularly the case. But how does that perception that somebody is coming in just to have basic needs met, how does that affect our care and looking at really deeply what are maybe some of the health and medical things that are going on. And what happens when somebody does come in and they have both significant medical and social needs? Do we find them difficult? Do we avoid providing care because that social piece is somewhat getting in the way? And there's also some data to show that, again, there's a perception that people who are experiencing homelessness are more likely to present to the ED at nighttime. Again, referencing back to that looking for a place to sleep, a safe place and shelter. But a study really intensively looked at hospital use of people experiencing homelessness, identified that it was pretty consistent throughout the day of when people experiencing homelessness presented. But what sticks out is that folks who are housed are less likely to come to the ED at night. So there may be a greater proportion of people that you're seeing experiencing homelessness as compared to the general population at nighttime, but really it's just because other folks who are housed may not seek out the ED as much at night. So all of this to say, really challenging our assumption that folks are just coming in maybe for shelter, maybe for rest, and that there's something medical going on. It may, again, not necessarily be emergent to require hospitalization, but this is where folks have access to care, as we've identified in previous conversations. So I'm going to jump to some outcomes of medical respite care, and I'm trying to sort of build the case and story to help us understand the link between the emergency room and medical respite care. And I will get there and make that link, I promise. So one of the first, we did a literature review, a medical respite literature review last year to look at really what are some of the outcomes of medical respite care that we're seeing in the literature. And what we found is that the existence of medical respite care identified a decrease in readmission rates following somebody's hospitalization, and that time spent as an inpatient and in ER visits decreased for those who were discharged to medical respite care. So the existence of medical respite has the opportunity to decrease the time somebody's in a hospital and potentially impact their readmission rate, which we just noted in the data was really high for folks experiencing homelessness. We also noticed some effects on service utilization. So once a person has been to medical respite care, they're more likely to increase outpatient service use. As noted, that's one of the key components of respite care, is to really get a person connected to that outpatient community-based care that's going to be able to follow their health ongoing. And one study found that folks spent increased time in housing and decreased time spent in other institutions. I will note that in that particular study, housing was part of the package, medical respite care, and then transition into housing. But that speaks to really the importance of making that connection and working towards housing for individuals in respite. And then cost savings. The data finds that there's cost savings for hospitals, even when the hospitals are the entity funding the medical respite stay. And especially this is the case when there's specialty medical care that's conducted at the medical respite setting, which is lower cost than receiving the same care in the hospital. One particular example of this is OPAT, or IV antibiotic therapy. Having an individual receive that treatment in medical respite is a lower cost than an individual staying in the hospital receiving the same treatment. And then finally, and really important,
Hey, Caitlin, are you with us? Hold tight, everyone. We will get Caitlin back with us as soon as we can.
all right, there we are. Apologies, everybody. I'm going to pick up where we left off here. All right. So hopefully this is where you all lost me. So we talked a lot about the data around medical respite, kind of from the numbers perspective, but I think it's also really important to highlight the consumer perspective as well. And consumers identify an important need for medical respite care, that it's a place for stability and opportunity to address health and basic needs, and that without respite, basic procedures such as knee and joint replacements and basic care are delayed because there's not an ability to develop a discharge plan. And it also limits a person's ability to connect with other needed services. When you're experiencing homelessness, the focus is on safety, right? And meeting those basic needs that healthcare and those other resources are not necessarily a priority. And overall, consumers identify a positive experience in medical respite care, an opportunity to connect with each other, to connect with support services, and also really meaningfully connect with their providers and the folks providing care within medical respite. And that overall, consumers report improved health-related quality of life and a positive impact on health management. So not only from a numbers perspective is medical respite care a valuable resource, but it's also something that is valued by the consumers and individuals experiencing homelessness that we are intending to serve. So kind of unpacking and summarizing these numbers, right? So medical respite care, we find can decrease ED utilization and time spent in the hospital and costs of providing care. And we see positive increases of people utilizing primary and community-based care more often and increases in healthcare use. That can look like a negative, right? Well, somebody's engaging in healthcare more when they've been in respite. That's actually a really good thing, because oftentimes somebody comes into medical respite and other chronic things are identified while they're there. They may be there for stabilization of an acute condition, but it finds and offers the opportunity to manage other things that might be going on that they just haven't had the chance and opportunity to address before. And what it does is then connects the person to appropriate medical care to address these things in the community, and potentially overall long-term reducing that hospital use because things are better managed from the outpatient perspective. So kind of linking all these things together now, why do emergency departments, why should they care about medical respite? Medical respite is that place that can potentially address those social service needs and case management needs that folks come in with that is not necessarily within the time purview of the emergency department to be able to address. There's potential to reduce overall health systems costs if people are not admitted or not admitted as long. It can improve health and healthcare outcomes. And I think really importantly, the reason why emergency departments exist is that medical respite care can save lives. And I think that is the essential goal that we're all trying to meet as healthcare providers. And when we're thinking about discharge planning for people experiencing homelessness, it looks different for those who have housing, resources, community supports, and caregivers. And it's important to keep that in mind, both because many of you maybe in EDs don't have a medical respite in your community yet. So thinking about discharge planning is important from a different perspective anyways, but it also helps in thinking about why might we want to build a relationship with the medical respite care if there is one in your community. And important things to consider is that even though a person's experiencing homelessness, they may have existing supports. And our presenters last week really talked about this and showed that beautiful relationship that can happen between an inpatient provider and that community-based healthcare provider, right? And if we're talking to those community providers, they're going to be able to support the person long-term with their care. So identifying who those people are for them, whether it's a healthcare professional, a case manager, or community health worker, and communicating care with them is really going to improve the discharge process. We also need to think about how we're discharging folks and what recommendations and how we're communicating that. You know, is there an issue with literacy or health literacy? If we give somebody a really long list of instructions that are complicated and hard to follow, and there's the person's not able to read that, we are likely going to see them back again in the hospital simply because they didn't get instructions in a way that they could follow through on them. Similarly, thinking about our recommendations and what we're discharging folks with, can they follow the medication regimen? Can they follow the diet that we have prescribed? Our supplies, are they getting an appropriate mobility device? A folding aluminum walker is not very durable for somebody experiencing homelessness and staying outside. They don't last long out there. So do we need to get things that are a little bit more durable so that the person has that increased support and is not going to come back into the hospital? Also considering cognitive status, we don't necessarily want to just assume that every person experiencing homelessness has decreased cognition. We want to make sure that we understand that, is this person presenting in a different state than they normally are? And that's when that communication with those support systems can be so helpful. And thinking about, again, as a hospital system, as a healthcare system, what can we do to prevent the person from returning? How are we supporting permanent, supportive, stable, accessible housing in our communities? And how are we connecting people to primary care and making that support? So again, making that connection between respite and the emergency department, right? This was talked about a lot last week, that folks often wait to come into the emergency department until something is really, really, really an emergency because they're worried about feeling stigmatized within that setting. When the person is connected with medical respite care, they're able to build a trusting relationship and a patient-centered plan. Additionally, folks may initially have a hard time accessing primary care, again, not getting that medical need addressed, and therefore getting them connected with respite offers the time it takes to get connected with a PCP. Folks also have difficulty getting to appointments. If a person's in medical respite, that's a key component, can ensure that
Hi, everyone. Well, Kaylin's having a hard time with her internet. I'm just going to jump in quickly. My name is Courtney Platson. I'm the Clinical and Quality Improvement Director here at the Council. So again, just reason why underlying why a person ends up receiving healthcare in the ED. Lastly, just needing to prioritize basic health needs. And one of the really important things that respite addresses is the long-term need of housing stability for health management. And just recognizing that the work, even though not every person in respite gets directly discharged into housing, it is such an important time to be able to get the documentation done, and so much work that can be done within respite that can help connect people long-term to housing in a way that the emergency department shouldn't be addressing, and often it's just not appropriate. We want to make sure that a client is getting the basic care needs met in the most appropriate setting possible. So how can ED providers be a partner for medical respite? So this is so invaluable, these partnerships that we developed. Emergency departments can be an advocate. There are some recuperative care programs or respite programs that receive referrals directly from the emergency department. I mean, I remember as an ER nurse, times that providers would say, well, this is a social admit. The client doesn't actually need to be in the hospital, but there's nowhere else for them to go to receive wound care or medication management. So they are soft admit. So it is appropriate sometimes for clients to be directly admitted to a respite program from the emergency department. You can be a collaborative partner. There are ways that our emergency departments can be partners at the table, whether that's through discharge planning in particular, but even we know that there are partnerships where hospitals use their community benefit dollars to help fund medical respite programs and help solidify these partnerships. We can use social workers to set up successful discharge planners or discharge planners from the hospital to establish these pathways for communication. And then supporting the financial sustainability. We know that Medicaid reimbursement only at its maximum can support 80% of the medical respite program. Some of the additional funding from a hospital can help decrease recidivism within the emergency department and decrease length of stay within the hospital. So there's ways that these programs are very complementary to one another. So here are just some 4 different examples of models of emergency department and medical respite relationships. So hospitals can be a driver of medical respite programs. This is actually the case in Portland, Maine, where we're about to open the first recuperative care program here in the state. And one of the ways that that need was identified was by the hospital. And part of that is actually looking at the data, coding for homelessness, using those Z codes to document the burden, how many clients are actually experiencing homelessness who are using the emergency department. So doing some of those needs assessment and combing through the data to be able to be data driven in identifying the need, engaging with community partners, figuring out who is currently working with this population, doing some process mapping of identifying hospital partners and community-based partners. Are we communicating and working collaboratively already? Are there pathways in which we are complementing one another? And what can be improved in these relationships? And we see this both in the emergency department side and the community side. I've seen where community partners go to staff meetings in the emergency departments to make sure folks understand the resources and making sure we're, as Dr. Work was saying, come back, continue those conversations every few months as we have new learners, staff turnover, different shifts. To continue those conversations and engage with community partners does take time and investment. We also want to improve processes. Can we consider how our systems are not meeting our current needs? For example, lower threshold for hospital admission from ED to stabilize for a transition to respite for multiple ED visits. So again, thinking of some of those social admits to prevent some of that recidivism long-term. So the short-term effort for a long-term gain. And with some of those improved processes is also how do we make it a light of a lift as possible for our emergency department staff to make these referrals. We know that the critical need is in front of an emergency room provider. They're dealing with codes, the trauma coming in. How do we make the paperwork, the communication, how do we make these pathways and processes as simple as possible for our emergency department partners? And then lastly, consider directly referring from ED to medical respite. So some medical respite programs don't accept directly from the emergency department. This is something that can be reevaluated, figure out how we can open up these pathways, something that could be established, and what might need to be different about the referral process from the ED versus inpatient, where that process might need to happen sooner so we can move the client out of the emergency department. So how do we use the ER to help be data-driven to open a respite? If you have a respite that doesn't accept directly from the ED, how do we broaden that admission criteria into respite to really help secure these partnerships? All right, we are going to go into our panel discussion, and I'm going to introduce our 3 panelists here. We're really excited and grateful for our panelists to be with us to share their knowledge and expertise. First, we have Nancy Carroll. She is a social worker here in Portland, Maine, and so grateful for Nancy to be on the call. I have the honor of working with Nancy in our community. She works for Homeless Health Partners, which is a medical outreach case management team here in partnership with Maine Medical Center and Preble Street Learning Collaborative. That's a lot of words and it's kind of confusing, but this is a hospital-based program that funds outpatient intensive medical case management. And they are such an important bridge to helping clients get connected to outpatient care to reduce recidivism and also connect folks to medical respite here in the community. Really grateful for Dr. Ricardo Cruz. He was the medical director at the Las Vegas Recuperative Care Center in partnership with Hope Christian Health Center based in Las Vegas, Nevada. And lastly, Monica Ray, she hers as well, Population Health Strategic Development Manager from Cottage Health in Santa Barbara, California. So thank you all for being here. I'm going to stop sharing my screen now. And Caitlin, I wasn't sure, I'm happy to launch into our questions, but just wanted to give you the opportunity in case your internet is working. And by your silence, I will imagine that that is a no. Well, let's go through. I just did very brief introductions. So I'd love to just turn it over to each of you to give some brief introductions about your program, your role at where you're coming from today. So Nancy, I'll turn it over to you first.
Yeah, so hi, I am Nancy Carroll, as Courtney said, and Homeless Health Partners is, it's a social work program that I am employed with by Maine Medical Center, as Courtney said. It's, we started a few years back to be able to really connect individuals experiencing homelessness with care in the community and from the hospital to the community. So we do medical outreach, and we can be found anywhere where a patient needs our support, which could be up at the hospital, in the emergency department, primary care, shelters. We go to patient appointments with them. So we're just sort of a wraparound support program for folks so that they can feel safe getting medical care.
And Nancy, we're just getting feedback or chat. People are letting us know in the chat that it's really hard to hear you. So I don't know if it's possible for you to come closer to your computer or add headphones.
Yeah, I can try that.
Thank you.
Like a volume piece too.
Okay.
See if I can get my volume up a little higher too.
Great, thank you.
Sure.
Ricardo, I'll hand it over to you to introduce yourself as well.
Okay. Hi, everybody. My name is Ricardo Cruz. I'm a family medicine physician. I work for Hope Christian Health Center. And we're actually a newer program. So the Las Vegas Recuperative Care Center has been around for a little over a year. My primary care practice has been contracted with the city of Las Vegas to help run and work with the community here. And so just based on our clinics as it is, we already service a lot of like low income homeless patients in our ambulatory clinics. And so we were able to discuss with Las Vegas to actually provide medical services here at the Recuperative Care Center. And so we actually just started in January. So we're still very new. So we're still learning a lot, and I'm learning a lot from everybody here. But you know, we have had partnerships already established with emergency departments. So most emergency departments will actually contact us with patients, and we do accept direct referrals. We're a 38 bed facility. We carry 2 extra isolation rooms. We've had a couple of COVID outbreaks here. But with that in mind, we're actually looking at expanding because we're becoming a lot larger than we can handle. I'm often seeing 3-4 referrals every day that we need to try to accommodate. We do have social services here involved as well. It's me, myself, as the medical director. I have a nurse practitioner, and we're looking at hiring another nurse practitioner for the later part of the week. With that, we also have street medicine. Street medicine is located at another facility that's called the Courtyard. The Courtyard here in Las Vegas is a place where homeless are able to sleep. It's a place for them to stay, and we offer primary care services there as well. So oftentimes our Courtyard provider will also refer patients directly to us. So we're constantly full. We're always looking at ways to be able to improve not only patients being discharged here to appropriate homes or hotels, but also providing the care here as best we can.
That's wonderful. It's amazing that you're already incredibly full and the need is just growing. And it sounds like you all are doing a really amazing job at creating a continuum of healthcare from the hospital to the respite program and to the street medicine. So that sounds fantastic.
Thanks.
Monica, I'll turn it over to you to introduce yourself.
Thanks, Courtney. I'm Monica Ray, Population Health Strategic Development Manager with Cottage Health. We're a 3-hospital system located in South Santa Barbara County in California, and we run the Cottage Recuperative Care Program at PATH, which is located physically at our local shelter, PATH Santa Barbara. And We offer 10 medical respite beds at PATH and provide the on-site support of a nurse and a community health navigator who addresses social needs and helps connect individuals to housing. We also provide follow-up support of a nurse and the community health navigator after patients exit the program. Patients stay about 90 days in our program and oftentimes do come back in for multiple visits. We've been operating since January of 2019 at 10 beds, and we did a small pilot at the end of 2018 before we started out. We typically run a full census of our 10 beds, and oftentimes we'll flex over those 10 and accommodate more patients if we have those referrals and as the shelter is able to accommodate. I can keep going. I'll pause there and hand it back over to you, Courtney.
That's wonderful. Thanks, Monica. One of the things that's really interesting that you mentioned is how you started as a pilot program first. And I think with Nancy as well, and Nancy's team at Homeless Health Partners also provides case management support for the respite beds in our local YMCA. And that really was the pilot to help launch what we're going to be opening in July. And so I want many folks out there to know that sometimes starting with 2 beds within a shelter or starting wherever you can get beds is a great way to help identify the need and to start building out some team infrastructure around being able to expand over time. So that's really wonderful. Well, the first question I'd like to start with is really, what was the identified need in your community that prompted your organization to develop the medical respite program or the medical outreach program? Like, what were the needs or unmet needs in your community that helped kind of launch you all into the space you're in now? And what's interesting is, Ricardo, your program is just opening. Cottage Health was just in 2019. So these are all relatively new. And in Maine, this is their recuperative care programs opening this summer. So certainly lots of new energy right now as well. So just love to hear from each of you kind of what's happening in your community that really prompted the growth of your programs.
2014, I think, when Healthcare for the Homeless, which was the federally funded clinic that was in the neighborhood where the shelter is in Portland, was lost their grant and lost their funding. And the agency Preble Street that works with individuals experiencing homelessness in the community, and Maine Medical Center recognized like a big gap in services at that time. And so they actually connected with Malia Haddock, who was our former program manager, and asked her if she could do some outreach in the community to see what the need was. And so she had a 40-hour outreach job, and they gave her 4 hours a week to sort of work on what the need was, which evolved into 20 hours a week because the need was great, to try to connect individuals with medical care and complex needs, and just sort of really connecting them with hospital care. So a year later, that evolved into program manager and one other full-time medical case manager. And so our Homeless Health Partners has expanded from that point to now, where we have 7 social workers or case managers working with our program. And we have a clinic that is where the former Healthcare for the Homeless was, which is a Maine Med Run program that is a walk-in clinic. And our walk-in clinic is open Monday through Friday, and it's like a mini respite in a way, because we have resting cots and spaces for people that don't have any place to rest during the day to just walk in, get basic needs met. We only have 4 resting cots. They're usually full every day. And so this evolution has just happened over time. And the whole idea with our walk-in clinic is to have really low barrier access, harm reduction, trauma-informed people. Like right at the front window, we have 2 of our Homeless Health Partners workers are called health guides. And the role there is to not necessarily be like a typical doctor's office receptionist, but social workers who are doing outreach. As soon as somebody walks through the door, they become, it's the relationship building starts as soon as somebody walks through the door, to help them feel safe accessing care. So within the clinic, we have a full-time nurse practitioner, and then we have residents and learners in all modalities in the medical field rotating through our clinic too, so we can sort of educate and expand the understanding of the importance of care for this population in the medical trajectory. So there's just a lot of layers. And so back just with an idea in 4 hours of, is there a need, has kind of evolved into our clinic and our social work program, and a lot of learners coming through, and just wonderful relationships happening in the community with the folks that we're working for.
Thanks, Nancy. That's really helpful. And I work in the Healthcare for the Homeless clinic that evolved, and so now we have Healthcare for the Homeless clinic. We have this clinic, the Learning Collaborative, and that Learning Collaborative is run by the hospital. And so it has become this bridge from the hospital to the community through our Healthcare for the Homeless program. And so that in and of itself has helped to bring and to bridge our programs in the community and the hospital together, and having learners come through and cycle through that Learning Collaborative and doing street outreach and getting to know our community is also taking that wisdom and knowledge back to the hospital, whether that's in the emergency department, inpatient, the addiction medicine team. So that has helped kind of in response to some of your questions that the folks in the chat were asking of how we can build the relationship between hospitals and respite programs. But I'll turn it over to you, Ricardo, to have you share what were some of the initial needs that helped to prompt the opening of your program.
Yeah, the biggest need that was found was COVID, being able to provide a place for patients, homeless patients with COVID. That's how this facility was first originally opened for. It was after that it evolved into the understanding that, well, sure, they had COVID, but there were also other medical needs that needed to be addressed that weren't being addressed. And right now, we are the only medical respite in Las Vegas. As big as Las Vegas is, we're the only ones servicing it. So it's evolved, and it's evolving even more rapidly now.
That's really interesting. I mean, everyone keeps saying that COVID kept highlighting the inequities in our system. So certainly COVID helped underline that in your community, but the need is much greater than just COVID. So that's,
yes.
Monica, how about you?
Yeah, I'm actually going to touch on, if it's okay, both this question about identifying the need, as well as some of the questions I see in the chat around building relationships with healthcare systems. And I'll just preface by saying we actually submitted a proposal and have been accepted to the National Healthcare for the Homeless Council conference for a presentation. And the topic is actually on this, building relationships with hospitals and why hospitals have such an important and critical role in recuperative care programs. So really encourage you to come to the conference, and we'll be expanding on this a lot more there, but I'll give you a preview of some of our thoughts on that in the response here. So I back it up a little bit, and I shared that we started in the fall of 2018 with a recuperative care program pilot, and we started with 3 beds, and then we expanded in January of 2019 to 10 recuperative care respite care beds. And really before that, we had a long and existing relationship with PATH, the local shelter, and we have what we call transitional care program beds. And so our transitional care program beds are about a length of stay of about 5 to 7 days. They're intended for a short-term place for a patient who has some medical needs to have a place to recover and then transition on to their next step, and for us to provide a little bit of medical support and social needs support while they're there. The recuperative care program, by contrast, has 90 days of stay and much more intensive case management and medical support throughout their stay. So with that, we had this transitional care program going for many years before we started the recuperative care program, and it served a really important function. And then we conducted a community health needs assessment in 2016, and we heard from the community that there was no respite care program, as Ricardo mentioned, for his area as well. There was just no place for these individuals who needed a place to recover with an acute medical need to have a place to stay. And so we saw that as an opportunity, and we saw it as an opportunity where the hospital was uniquely positioned, because we could also connect in their care through documentation in our medical records and through our expertise and access to care, and then also our ability to address social needs. We saw an opportunity to partner and to really staff on site at the shelter and have our staff be part of the recuperative care program. And I won't ever forget, and I think we've touched on it a little bit here today, but I won't ever forget our medical residents who work with some of their lowest income population in our hospital. They said in a focus group we hosted as part of the community health needs assessment that they feel like they're experiencing a revolving door. You know, patients come in and they go out and they come back in, and they're doing a great job of addressing the medical needs of the patients, but they're just putting a Band-Aid on the actual root cause of the problem, which oftentimes is this homelessness and inability to access housing. And so that really stood out to us as a hospital, and that understanding of, you know, we're doing the best we can from an access to care and medical care standpoint. But then there's so much more to this issue, and community partnerships that are needed to be able to address the root causes of their challenges. So then now we actually run the recuperative care program, which is the 90-day program, and the transitional care program. And the 90-day, the transitional care program, you know, in concept, before we launched it, we had one idea that we would refer patients directly to the recuperative care program. And then after we launched, we found that the transitional care program to be a really important tool in terms of our referrals into the recuperative care program. So somebody mentioned in the chat about having to receive patients from the hospital, regardless of whether those patients are maybe appropriate for their respite care program, and because hospitals have a need to discharge these patients and discharge them safely. So what we found is that the transitional care program really helps to meet the need, you know, meets the need of the hospital and the discharging and the patients who need an immediate place to go. Not all of those patients are ready to commit to 90 days in a program. Not all of those patients have a medical need that would warrant a longer recuperative care or respite care program stay. And so we go through a screening process before they come into the respite care program. And there are really three main parts of that screening process. One, we screen for their medical needs to make sure that they are, from a medical standpoint, appropriate for the program and have a medical need. We screen them from a social needs standpoint. We ensure that we have the proper supports in place if they have more severe and persistent mental health needs, to be able to support them in the program especially. And then we also ask the patient if they're willing to participate and come into the recuperative care program for 90 days. And a lot of the times they say yes. Most of the time they say yes. Sometimes they say no, that they're not willing and they're not interested. And as long as they can vocalize a yes, we will take it. And so that's a key differentiator, I think, between our program, and something we've learned to be really valuable is that the hospital then has a place for the patients to land, and that's addressing the need. The recuperative care program is really working towards what the community needs, what these patients need, and what's needed to improve the health of this population. And that's also something that the hospital, from a hospital standpoint, really cares about. Oftentimes you hear this described as community benefit. We discuss it as population health, focusing on the health of the community and the subpopulations therein before they get sick. And so I think those two pieces, you know, if you approach your hospital and have that conversation from that angle of, you know, finding solutions to what their immediate needs are and the day in and day out operations, as well as addressing really what they care about, and that's the health of the communities that they're serving.
It's really helpful, Monica. I really look forward to that session at the conference. I think the other piece, what I'm hearing, is how do we leverage the expertise and resources of both hospital systems and the community-based organizations or the healthcare for the homeless programs or recuperative care. And those are complementary often, they're not in conflict. And so I know that there can be tensions or challenges around discharge in particular, because the needs and resources are different and varied, or the drivers of discharge. But often if we can figure out those partnerships, they benefit both partners. So I appreciate you lifting that up in particular. I know we only have a few minutes left, but I would love if one of you has just a patient story or experience you'd like to lift up as an example of how this partnership between emergency departments and respite programs have benefited a patient, or if there's a patient story that just kind of is top of mind that you'd like to share, just to demonstrate the impact. And we're talking a lot about health systems and staffing, but I would love to hear if someone has a story of that they would like to lift up.
I have a story. Actually, just more recently, we at our medical respite, we do accept hospice patients as well. And so we had received a hospice patient, elderly. She wasn't going to be long for the world, but when we do have our patients here, they meet with our social workers, and we were able to find out that her husband was in a hospital as well, actually a different hospital. So she had come from one hospital, and we were able to track down her husband, who, believe it or not, coincidentally was also on hospice. So we actually accepted him as well.
Goodness.
And so we were able to find him, bring him in, and we made some accommodations within our facility so that they can actually be next to each other, so that they can actually touch each other, as a matter of fact. Unfortunately, he passed away first, and then her shortly thereafter. But we were able to actually at least unite them at that stage of life, rather than leaving the uncertainty of where their partner was.
That is incredible, Ricardo. Thank you for sharing that. I mean, what a way to support dignity at the end of life, and to help them be together and at the end of their life. So that's really special. Thank you for sharing that. Nancy, Monica, is there anything you'd like to lift up? Any story that you'd like to share?
Well, since our respite program is just like getting up and running, Courtney, we do have the YMC respite, and Kat's the primary case manager for that. And so I don't have a specific story about that, except that the men that have been going to the Y have been pretty much not returning to homelessness. They typically are able to like go from their respite at the Y to like a self-pay room or some other form of housing, rather than returning to homelessness. So I just wanted to put that out there in terms of what kind of the success of respite care for folks, that it's a very positive trajectory if that's in place.
Thanks for sharing that, Nancy. And I agree, as someone who has worked in respite programs, they are life changing. And once you have worked in one and see the impact, you are sold, that's for sure. So thank you so much. And I just want to thank each of you, Ricardo, Monica, and Nancy, for coming and sharing. I'd love if you each could maybe drop a link of your organization so people could learn more. Of course, our time is too short, but love to be able to share with others the great work that you all are doing. And I'm just going to quickly share my screen as we wrap up. Just want to share that the National Institute for Medical Respite is a special initiative of the council. We welcome, there's so many amazing resources that Caitlin and Julia and Stephen are working on. They are resource machines, and there's so much amazing information going on to this website. So encourage you to go check it out. You can see all the wonderful work being done, and a lot of wonderful resources that is directly applicable to your programs. As I mentioned and dropped the link in the chat, we are so excited that we are having an in-person conference for real in May 10th through 13th in Bellevue, right outside of Seattle, Washington. It's just going to be such a wonderful time to finally have our community together, and our theme is toward health and belonging. So we really hope that you join. We already have 700 folks registered, and we are thrilled. And just want to thank you all so much for working with us today as we work through a few tech issues, but just really appreciate everyone's participation and patience with us. But please follow us on social media. And once we close out, we're going to have a survey. So we really appreciate and value your feedback. So let us know what we can do better next time. So thank you all for joining us today. Hope you have a wonderful rest of your day. Take care.
Thank you. Bye.